So the problem that physicians are seeing now is they're receiving more and more data and pieces of information. Over time, we saw them evolve to different purposes. With the advent of E&M coding, they became a tool to help them calculate the correct codes. And then we had meaningful use, and physicians were starting to collect more information to document quality measures and their performance. With those requirements came an increased burden to document information that they might not necessarily have documented before. To reduce this burden and give physicians better information, I think a number of things are going to have to happen. We're going to have to balance the regulatory requirements and the needs to be able to document that physicians are providing quality care so that we pay them appropriately with their efficiency and ability to see patients. So we're going to have to come up with a mechanism where we can process all of the different information coming in and turn it into knowledge rather than pieces of data. It needs to be knowledge. Similarly, we need to be able to pull data out of the electronic health record for other purposes that don't require the physicians to document information that they wouldn't need to as part of the care of the patient.
MITRE has experience with health data. We've been researching different components of health data for over 15 years. We've had research projects in the areas of quality measures. We also are looking into policy simulation. For example, we're working together with academic partners to research using predictive analytics to identify risk factors for patients who may have sepsis or septic shock. We're working with Johns Hopkins on a project looking at ways to identify sepsis more quickly.
By taking all those information sources as you identified and just presenting that the patient is at risk of substance abuse or sepsis, that would save the physician a lot of time as well as improving patient outcomes.